and thank you for introducing us and for this session, and thank you for everybody for joining. So yes, I'm the Chief Executive of Irish Pharmaceutical Healthcare Association, and I'm delighted that I'm joined for this discussion that I've relished myself on health reform by former HSE Chief Executive Tony O'Brien and Vincent Barton, Principal with Prospectus Consulting, both of whom I've worked with over my period. They will introduce themselves in a moment. Just to say that I've been with IPHA 6 years, but in previous life I was 10 years as Special Advisor on policy with former Tónais Mary Harney, and we had a lot of interesting reform issues coming and going during that time. So with that, I'll ask Tony to introduce himself and then Vincent.
Thanks, Oliver. Good afternoon, everybody. So as Oliver has said, I was for 6 years the Director General of the HSE. Since that time, I've done a bit of work with the Business Post as a health policy analyst. I'm a strategic advisor with the communications firm of 360. And perhaps more relevant to today, I'm also the director of a biosciences company in California with a recently FDA-approved product. So that gives me a kind of a rounded perspective on your sector and the health sector that we're talking about.
Thanks, Tony. Vincent?
Good afternoon, everybody. I'm Vincent Barton. I'm the healthcare lead in Prospectus Consultants. In health, Prospectus has been working for about 30 years across this health system, really. So we work for pharma, biotech on the private side and private providers, but we also work for everyone from the Department of Health to the HSE to down across public sector providers as well. And the first part of my career, I spent mostly in the Department of Health, and at the senior end of that, I was responsible for the finance side, for acute hospitals and for change management, not all at the same time, but on individual occasions. And I also spent 2 stints in Brussels as health attaché during Irish EU presidencies.
Great. Okay. Thanks, Vincent. That's brilliant, Tony. So just by the way, just to reiterate what Emer said, it would help everybody if everybody could be on mute, if you don't mind, and off camera while we're having the session. You might just check that for yourselves. Okay. So look, health reform is a thing that has been talked about in the health sector forever. It seems to be a constant topic of reform. We had of conversation. We had going back to earlier days. You know, I remember very well when the British Labour Party came in and they were talking about investment with reform and investment reform. And from there, that seems to be to sort of embed reform in the political speak and policy speak for a long time as a permanent feature. However, it's hard to know sometimes if reform, how is it proceeding and what are we learning from reforms that work and reforms that may not have worked so well. So we're not intending to have a big history lesson here today. What we're going to do is talk between the 3 of us, and we'll invite some questions, obviously, on the chat line. Talk between some of the lessons from the past, and then we'll move on to looking at what is happening at the moment, of course, with COVID as the massive disruptor in our health services and massive challenge. And then we will look at what reforms, in the opinion of the panelists here, what needs to come next. And maybe finally, if we have time to say, well, what lessons could we draw for IPHA, particularly for our engagement with the state authorities on improvements to medicines, policy and reimbursement. However, but with that said, the first thing I wanted to do was to ask Vincent and Tony separately, and I think I'll start with Vincent. Can you give me an example of a significant health reform that worked and why?
Sure. When you look back, Oliver, I suppose the glib answer would be it's easier to find a menu of unsuccessful than successful ones. But that said, there are quite a few examples which we can learn from, I think. I was thinking about it, and one that has really struck me is actually a public health reform, which was the smoking ban, which has kind of been forgotten or checked up. But in fact, I think it had very significant success elements in it. So for those who were smoking at the time or hadn't reached smoking age, this goes back to 2004. And it was the first in the world, the Irish ban on smoking. And it was a huge health initiative, actually, a huge health measure. And if I think about what the success features were there, just very briefly, there were a couple of characteristics. And to just step through them. There was actually a slow burn prep of the political system. There was an Oireachtas committee a couple of years before, and it was Alan Shatter actually who led on it,
Right.
which kind of sensitized the houses of the Oireachtas, if we put it that way. But there were a couple of more distinctive things. There was a clinical champion, a guy called Luke Clancy, who was to the fore. There was a crusading civil servant, if I may put it that way. There was a man in the Department of Health who's since passed away called Tom Power, who was passionate about this, but had great tactical smarts. There was political determination. It was the current Taoiseach, actually, who was the minister at the time. And I'm not carrying a torch for anyone here, but he was very determined. There was a plan, overt and covert, and something which doesn't often happen. There was a kind of twinning of agendas. So this was lined up, this public health thing was lined up with the kind of occupational health, and then with trade union interests, bar workers, that kind of stuff. That was very clever. And I suppose the final thing was there was stamina. And they faced a lot of resistance from very powerful interest groups. And the measure now is considered to save about 400 lives a year ongoing. There were two other things. They had evidence, right? So they were able to back it up with that. And they also had money. But in fact, this wasn't really an investment case thing. This was, and that's important. So I suppose if you roll all those up together and you accept that having a good idea is never enough, Oliver, those look to me like features of a successful and brave initiative.
Right, Tony, what's your take on a good example of some reform that's worked?
Well, I agree very much with Vincent's example, first of all, and it's good to have an example that's not about changing the health system, but about changing the health prospects of the country and seeing what policy can do. But my example would be the 2006 cancer strategy, which led to the creation of the National Cancer Control Programme, against which there is solid evidence of delivery, but it had some similar characteristics. So it started off with the gathering of evidence. So it was very much an evidence-based policy document, brought to government by your former boss and my former boss in that sense, Mary Harney, who managed to get a very clear political commitment based on that policy. And then it led to an implementation strategy which lined up the evidence with the existing resources, the new resources, and followed through so that there was a seamless line of connection between what the clinical evidence told us needed to be done and the actions that were subsequently taken. And one of the key elements of that was to energize clinical leadership and to give genuine clinical authority. And it wasn't easy because there was lots of opposition to the contraction of the delivery of curative surgery services from about 37 locations down to 8 or 9, depending on how you count them. And significant opposition. Even junior ministers resigned from government at the time. But what stands out for me was the continuous and unambiguous line that flowed from the evidence through the policy and then the operational processes necessary to deliver on that. And when we look back, and it's a 10-year journey with cancer, we can see very significant evidence of the benefits of that program delivered. And the reason I highlight this continuous line, this seamless train of thought, was because it wasn't the first cancer strategy. There'd been one before, but it had been nowhere near as successful. The evidence was the same, the overall idea was as good, but the delivery was compromised by the fact that there wasn't genuine political commitment to it, which then didn't result in the necessary process change that enabled it to happen. So that would be the standout example for me. And of course, it's very much linked to the focus on cancer that Micheál Martin had and that Mary Harney took up after him.
Yeah, that's really interesting. Tony and Vincent, both of you sort of agreeing on this question of it's not just one thing, and it's certainly not just one good idea, and even good ideas may not get over the line or may not find traction. And the sort of the commitment to persistence and indeed political, but also interestingly sort of champions within the system, so to speak. You do need that. My example that I would like that I bring, and I know people will know this from what I've said before, it is of course around the same time because I was there, but it was the restructuring entirely of the Fair Deal, the nursing home support scheme, the financing, the balance of financing between the state and individuals for provision of long-term care. And it had been, but I'd introduced one of all those elements that both Vincent and Tony, you've said were there too. But one thing there was a crisis as well. And there was a complete collapse in the legal basis for charges nursing homes and public nursing homes and so on and so forth. And that was a difficult thing. And so out of a crisis, it provides an opportunity to recalibrate. But one thing that was also common to that was it took a long time. The crisis started around late 2004, early 2005. There was no way forward. Well, the Fair Deal scheme came in 2009. And it was only in fledgling state at that point. So these things do take a long time. I would emphasize again, there was a pile of evidence, fabulous work done in the backdrop by a small group of civil servants, lots and lots of evidence. Every report from everywhere had been written and had been read, and absorbed. And a good lot of it wasn't as clinical outcomes driven, I suppose, that one as either smoking or cancer. But certainly there was a sense of there had to be an outcome desired was very clearly, we were very clearly able to articulate that. But so going back to that question, how important is it, would you think, either of you, jump in whichever you like, on having bounded objectives? So we've had reforms where, let's say, it's a whole health strategy, and that seems to have everything happening at the same time. Whereas with smoking, it was sort of bounded. With cancer, it was bounded. With Fair Deal, it is bounded, and it was certainly bounded in that case because it didn't apply. Everybody knows it doesn't apply to home-based care. But how important is it to have sort of a boundary around this is doing this much, but it's not going to address everything at the same time? What would you comment on that? Whichever you'd like.
Well, I'll probably jump in. I think that the discrete nature of those things, where you can have a beginning, a middle, and insofar as you ever have an end, a kind of an end point, there is no end, of course, was really important for all three of those things. And we can contrast that, I think, with say the Big Bang stuff that the coalition government of 2011 tried to do. Let's remember what that was. That was universal health insurance. That was abolish the HSE, and all under this title of future health, which tried to do so many things that it was impossible really to line up all the necessary forces to achieve it. And those in the system who were charged with delivering any of it couldn't understand it. It was incomprehensible, and ultimately none of it really happened, of course.
Well, Tony, is Sláinte care a bit like that? Would it be suffer from the same trying to do everything at the same time, or is it bounded enough?
It has been unlucky in timing and the nature of the government that was in place when it came into being, which didn't really have the power to implement any of it. And obviously now we're into pandemic times. But I think it was at least more honest in that it said that this is a kind of a vision for where we'd like to be quite some time in the future. And what we have to do is work out the different steps to get there. Now, working out those steps has been a bit slower. It's different to the future health thing. Future health thing sort of tried to smash everything up without having a vision of the future, really. And so I don't think the two things are truly comparable. Sláinte care is, of course, an enormous undertaking. And even the 10-year horizon, I think, is, even if we'd started it at the beginning of those 10 years, would have been extraordinarily ambitious. But it doesn't do as much damage as future health did, and that's to its benefit, I think.
Yeah, just to pick up on Tony's comment, my go-to example of how not to do reform is actually the UHI thing. That I'm happy to expand on that if you want, but I think my answer to your question would be that bounded is really important. And why is it? It's for me, the half-life of change in the health system is at least 5 or 7 years. That's the half-life, and you can actually kind of plot that. That's where it works in the end, and putting yourself hostage to 10-year plans, which are other than strategic, in an environment where the mini cycles, like in terms of therapies, in terms of business models and everything, are much quicker to change. Really, you're almost bound to failure, I think, if you go about these things a certain way. I was thinking the other day about, that off-quoted model of the Swiss cheese for adverse incidents, and how if the holes in the cheese get lined up, something goes wrong, but most times it doesn't. It actually works in reverse too. I think a successful reform program, nearly you have to actually get through all the holes that are there. It's the cheese is the problem.
Yeah, so Vincent, but if you said that in regard to the smoking ban, there had been a consensus built up. Was that internally or externally or both within the department? And is that a feature also of any successful reform from the and especially with connecting into the political level?
I think that almost any significant reform in health comes with built-in resistance, baggage, vested interest. And I think so. It's wrong to presume, I think, on support because it's a good idea, as we were saying earlier. And I do think, particularly within the, if we take three things which are absolutely indispensable, I think determined, sustained political leadership, a clinical champion, and I think less well observed is executive support, senior executive support. And I don't just mean roll along support, I mean really throwing your weight. Most of these senior civil servants and senior public servants have a huge menu to deal with. And I think that the things that have worked have always had, if you can call it, a slightly crusading senior public service part to it. While we're there, I don't think it's useful to combine it. Evidence would tend to suggest that it hasn't been historically useful to combine the senior clinical with the senior political support, because I think they play two different roles. So just because your minister is a doctor doesn't necessarily mean it's easier to drag it over the line.
Sure. What would you say, Tony, about that in terms of building up the support from those different, particularly those different sort of stakeholders?
Yeah, and the two examples that we've given as success ones have been one that have been very much grounded on evidence, and where you go through a process, usually the creation of a broadly based expert group, some degree of public consultation, publication of a discussion document, usually hearings before an all-party group of some sort in the Oireachtas, and you gradually build up the concentric circles. Challenge, of course, is to have a political leader in the form of a minister, and for both of these, we had these characters who were able to commit themselves to a continuity of thought and then steer that ship through. And Vincent's absolutely right. You do need both a clinical lead, because we're essentially talking about things that are clinically grounded and have evidence behind them, and then someone on either the policy side or the administrative side who's prepared to be equally committed and the sidekick, and ideally have enough time to do it, and that brings it through. But that does speak to the fact that successful change takes time. The flash bang stuff, which some politicians are attached to and the media quite likes, very rarely bears fruit.
I think that's right. Although I think if one were to be fair, in the political world, the not just the incentive, but the pressure to be able to say you will be delivering improvement or change quickly is really, really strong and extremely hard to resist, or let's say to cope with.
Yeah.
So yeah, the question is, how do you deal with that? And I suppose a lot of us who've worked in political area, we have learned that some of these lessons about how you can balance that between, you have to offer confidence to the public that there will be improvements in the short term, but then you also have to say, look, and we really have to go for the long term thing. And the hard part, we've experienced all that with of course emergency departments and waiting times and all that sort of operational challenge there. Politicians being under massive pressure to say everything's going to be okay this winter if we just do X, Y, Z. But in terms of, going back to reforms and other, and so those examples, there are obstacles, as Vincent has, and I think, I don't know how much you, Tony, referred to, but the obstacles are not just sort of mute, dumb things. They are sometimes people do not want this. There are obstacles which have to be overcome. And what are the hardest obstacles that you would have encountered, and what are the best strategies to overcome them?
I think we should be honest enough to say that this isn't specific to health reform. I think any change in any context, anywhere, the literature tells us is all about identifying and dealing with and overcoming people's almost automatic resistance to change. But the biggest thing I think that has tended to dog healthcare reform, to use that term, is the divergence between doing what's right nationally and doing what's wanted locally. So in order to reap the benefits of medical advances, many of which are technological, many of which are based on gaining evidence that the centralization of certain services has benefits to the patients who experience those services, that does mean repurposing some locations so they no longer do A, but they do B instead. And it's really about having a coherent set of proposals that deals not only with what's being taken away, but what's being done instead, in order that the individuals concerned, be they clinicians, local politicians, local community groups, are able to feel that they're getting something positive out of the change. Otherwise, you just build up resistance. And this was evident in the cancer strategy. It's been evident in so many others. And then you have the normal human factors. If you've built up a service which has never really achieved the scale it needs, but you've devoted your life to it, you don't want to be excluded from that area of work. So you need a pathway to follow that work to where it's going. You need a degree of innovation and flexibility about how your job might be structured. You need to continue to have a voice. Or alternatively, if you want to do something else, you need to be facilitated to do that. So you have to deal with those human factors at every stage. And the changes that I've observed that have been more successful have been ones that have been communicated and constructed at a level that enables the human beings who make those services work to see their future somehow or other within that changed environment. If you don't deal with that, you just create significant barriers of resistance.
Yeah, Vincent, like this brings us, obviously we think about this, Tony's point about local change and resistance to change and the opposition, especially in relation to hospitals. You have a particular and expert knowledge about hospitals, and is this what's the challenge? Is this what's holding up the challenge with the hospital groups? Do you think, or why is that reform particularly slow or stalled? Is it there? Would you offer some views there about reform in the hospital sector, particularly, and this restructuring aspect?
Well, I suppose well, first of all, I suspect from the subtext that all three of us probably agree, there hasn't been said out loud, that structural reform is the one that people tend to go to, and in fact, it's, for me certainly, it's probably the least consequential, and it can divert and subtract from energy and emotion and time and everything. On the hospital one, I suppose it's understandably challenging because it triggers nearly all the big change issues, in that you're dealing with the largest single component of our health delivery structure, perhaps the most traditionally influential. They're the best organized in terms of organizational constructs, so they're the big beasts in the healthcare delivery system, and they hoover in generally rather than spew out. So in terms of integration with the rest of the system, you're dealing with the well organized blocks. But I think there are ways to deal with that, which for me is always to work with the kind of where the power lies. So it is possible, for example, and this has been discussed, to kind of make the hospital groups significant agents of change, rather than saying the story here is that we're actually going to abolish you and sweep you away.
Yes, nobody wants to be abolished.
Which picks up Tony's point. So I think the hospital groups thing, in fact, the evidence is, I think, that without real legal basis to date, if we're talking about the recent ones, that there are plenty of examples of them actually having just got on with it. On the more personal level that was being referred to, I think there is something a bit like the 7 stages of grief. When you're dealing with individuals or small groups of individuals, there is the, at first there's shock, and then there's horror, then there's disbelief. But in truth, in my experience dealing with people on the change management side, a kind of determination and consistency from the change agent side is really important. And in a sense, that brings its own comfort. People feel they're not just being mucked around with for the sake of the latest plan, which will be gone next year. And I think that's a vital part of change, be it large scale or small scale.
Yeah, clinical leaders, consultants particularly, but nursing leaders as well in hospitals have tremendous reach in their community, and indeed, I believe, high degrees of trust. And yet that can go either way in some of the reforms. Sometimes that happens when they feel they may choose to resist a change, or they may get behind it. But in the cancer side, Tony, it was felt necessary to bring in Tom Keane, who actually from a zero start, I think developed a huge amount of trust in the public as a whole, and then with his clinical leaders, with his clinical colleagues in oncology across the country. That was very important. If one was planning a reform project, wouldn't you look for a clinical leadership both at regional, or let's say national level and regional level?
You absolutely would, and obviously the other thing about Tom Keane was that he came without baggage. He was Irish, but hadn't really worked in the Irish system. And also the sense of momentum was created by the fact that he was coming for a period of time and would go away again. And he wasn't therefore hostage to anybody, and could afford to do some of the tough things. But clinical leadership is really important. The hospital groups have achieved some interesting things within them. And there's been quite a lot of patient flow changes, quality uplifts. And of course, they've all come with a strong emphasis on clinical leadership, and have all put out their clinical directors and chief clinical directors as significant spokespeople for what they're doing and the changes they're making. The only reason they haven't succeeded in the way originally intended, unfortunately, was they had a difficult birth. They were part of that future health thing they were supposed to be legislated for. They never were. To pick up on Vincent's central point, we tend to have an obsession with changing the structures. We go back over 20 years, we created a regional health authority. It was gone within a few years, then the HSE, then various changes within that. Then the HSE was to be abolished, then it wasn't going to be abolished. Now we're heading to regional structures within the HSE. And these things have a certain attractiveness at one level, but actually they're just huge disruptors to the system. Most people continue to do essentially the same job in the same place that they did before, and what they need is process change before they need structural change. They did a review in the north recently, led by Rafa Bengoa, a former health minister from Spain, who essentially made that point, that what's missing is some of the connective tissue that follows patients through the system. And messing about with health board structures doesn't change that. And we have some of that, and we're seeing it play out now to some extent in some of the challenges that the HSE is going to face with the vaccine rollout. There are some basic systems and processes that it has not got, which would have been far more useful to it than any notions of creating regional health entities or HSE or saving it. So at some point, and hopefully through the vehicle of Sláintecare, which still seems to be alive and kicking, we need to get politicians and leaders to focus on the embedded systems that will transcend all of these structural changes.
Yes, I agree completely. Also, the structural changes takes up an awful lot of what is in fact a scarce resource, which is the time of the civil service, the administration, the Dáil time, legal time. It takes an enormous amount of time, and it doesn't really deliver much, identifiable improvements, as compared with driving change by clinical standards and by processes, as Tony was saying. So if we were to focus on those, it's what is the clinical outcome you're looking for, and how are you going to organise your process to deliver that? I think the structures we have at the moment are well capable of being used to deliver those. There's no question in my mind. But Tony, you mentioned the vaccination. So let's talk for a while about the COVID crisis and the pandemic in general. How do we assess what the pandemic is doing to our health services? Is it driving permanent change already, or is it a sort of a massive interlude when we get back to reforms such as Launch Care? How would you assess that?
Well, I think some of the changes that we're seeing on the ground are both driven out of necessity at high speed to deal with the pressures that we're currently seeing and have seen for the last 9 months, but are also things which are consistent with the future needs of Sláinte Care. So I'll just give one small example, which is called ED in the home, which we've seen roll out in various parts of the country. It's where rather than patients, particularly frail elderly patients, are brought to hospital in order to avoid traffic into the hospital ED department, an ambulance car with some ED staff goes out. They look after the patient in the home. Depending on the circumstance, they'll try and keep that patient at home. This is absolutely consistent with what Sláinte Care wants to do. And although it was already planned, it's now been fast-tracked as part of the immediate response to Sláinte Care. And there are other examples, which hopefully will still be there when the pandemic is over.
What do you see, Vincent?
Yeah, I'm with a couple of colleagues. I'm working right in the middle of it, as you know, Oliver, on the acute hospital side, and it is interesting looking at it through this lens. There's actually quite a range of stuff that has been commented on. Changes in teleworking, remote medicine, but it's beginning to raise other things too. So I suppose there are questions emerging now about whether some of the activity that went on was actually needed. I'm talking about clinical activity. Can we do it differently? But there's also maybe, and it's too early probably to tell the impact. Is this exposing unnecessary therapies? There's interesting disruption to the clinical hierarchies. So the public health doctors have come blinking into the light, so to speak, and you saw that there was industrial action being threatened. And that's, I think, in terms of enduring effects, there's things like that are interesting. The HSE brand, that's suddenly better than it's ever been. That necessarily wasn't a terribly high bar, but genuinely, I think there's an asset there, which if the vaccination stays on rails would be good. There's a change in the perception of big pharma, which is something you probably want to talk about later. But
we'll come back to that.
Yeah, and I suppose, and maybe this is a bit conceptual, but there's something going on, I think, about the importance and accessibility of evidence. I mean, everyone in the country is an epidemiologist now. All of a sudden, you'd have to think that the awareness and understanding of that doesn't disappear just because we're all vaccinated. So there are interesting things going on, Albert, definitely.
Yeah, obviously the fundamental part of Sláinte Care is to move more into two parts of it, as I see it anyway, moving more into primary care than secondary, and second of all, a change in what we call public entitlements. That is to do with what you're entitled to as a matter of law in terms of medical cards or full coverage for primary care. What Tony has highlighted actually is about services moving into primary care, and I agree, it's very hard to see those being reversed back into hospitals. We say, why would we do that? But there may be people who want to do that. Who knows? But building on your earlier points, if the evidence is there that this works better, if the processes can be supported, and if the political leadership is there behind that, then you could imagine that any thoughts about moving back into let's go back to the way we always did, that won't work. What may not be happening with, or may be happening with the under in a sort of a deeper current, is the question of entitlements, which comes into the role of the health insurance market and all the rest of it. Are we all, effectively public health patients at the end of the day? We are in a public health pandemic, but will that persist? It's very hard to know. Have you any thoughts about that?
Yeah, I think one of the big losses under the universal health insurance project, which Tony and I both alluded to, was perhaps the most revolutionary feature of that was going to be that there had to be a basic package of entitlement described for every citizen. And at the moment, we only have eligibility, as you know. And that that actually would be a game changer, because suddenly the relationship between the citizen, patient, and the state is defined in a different way. And I suppose, Oliver, you're right. There's at least some feeling that when the chips are really down here, the state has a responsibility and the citizen has an expectation that their health will be looked after. And that's at the heart of social care. So I do feel the dial has probably shifted on that one. The other thing that has happened, just to mention quickly, is that lots of things which had kind of been planned or put out there, like, for example, the measurement of the shortfall in capacity in ICU beds, in general hospital beds, in VPs, in consultants and stuff, a bit like those funfair things where the waterfall of coins falls over when you drop in your euro or whatever. There's been spending in the last 12 months to tip those things over, which we would have taken a decade to get to normally. And that's irretrievable in itself, which is a start. And they have a pull-along effect, because suddenly we need the staff and we need... So the base has been adjusted, I think. Interesting to see what the appointment of Robert Watt as Sec Gen in Health, facing back towards his former job, what that'll look like over the next few months.
I think the biggest impact isn't necessarily on the temporary changes that are being made to eligibility and any special arrangements being made under safety net and the previous takeover of private hospitals on a temporary basis. I think the fundamental issue is that everybody now has a much deeper appreciation of the value of an effective, functioning, right-sized healthcare system, and also recognition that being VHI positive isn't a particularly big asset during a pandemic.
No.
And consequently, the tolerance of those of us, 50% plus, who could insulate ourselves from the limitations of the publicly provided healthcare system, that we were somehow safe, I think that's gone. And therefore, I think there'll be a much greater public and political appetite to do the things that need to be done in order to sort out the process issues that have existed and the capacity issues that have existed for far too long in the publicly provided healthcare system. So I think the old debate around healthcare is gone forever. I think we're in a new phase. And I've taken some criticism for an optimistic analysis I wrote about the potential benefits of Robert Watt moving from deeper into health and what it might mean. And I think it's a seismic move for him to make, given the contribution that he's made in the past, and also to have a civil servant of that influence across government embedded in health is almost in itself a sign that there is now an understanding of the economic importance of having a fully functioning healthcare system. Much as they do in Germany, for example, they see a good functioning healthcare system as part of their economic offer, part of their draw for local investment. And I think we're going to have to get to that stage fairly quickly.
Yeah, we're going to bring forward a study, a relatively small study, but useful, same from the German consultancy IPHA, showing the economic value of healthcare investment, which hasn't been done that much in Ireland so far, and I hope that Robert will find some merit in it. But but it is true. This is a very important thing, and it reminds me that one of the reasons why, in the back of, I think I'm right in saying I don't normally characterise what my former boss Mary Harney's thoughts were, but one of the reasons why at that stage she went to health was she wanted it never to be said again that health is a place that no minister wants to ever to go to again, that you're sort of condemned politically to go to health, when she had to have more or less some degree of choice as a thought. She could choose to go there. She wasn't total choice, but theirs was. And I think that has been the case. In fairness, if we were to James Riley, he also chose to go there. We may disagree with how successful or indeed well crafted the policy was, but still, it was a choice. And I think it's very important that senior civil servants also should want to go to health. And there's where I see one of the strongest signals from Robert Watt's move to health. And indeed, your own Tony or Paul Reed's in the past. So I think it's a very, very important thing, because it's very hard, Vincent would relate to this, but it's very hard to imagine what the atmosphere in health was in, like, say, the late 90s, early 90s, this idea of Angola, both for civil servants and for politicians. That itself was a drag on improvements in the system and in terms of political backing. So,
yeah, Albert, just to say on that, and Tony and I have both done academic gigs in policy making and stuff, and it's interesting because in the theory of policy development, health is generally categorized as low policy. It's high policy now. everywhere in the world. And I know I often think of that quote, Virchow, the kind of father of modern pathology, has said that politics is just medicine on a larger scale. And I think it should be set up in bronze outside the Department of Health at this stage.
Let's go back to the discussion on reforms then and say, what do you think are the reforms that are most needed now or next? Tony, do you want to go with that?
Well, I think that the underpinning health data is critical because that enables the system to operate in a more integrated way. I mean, when we get into this big debate about our relative performance on the delivery of vaccines, which unfortunately is coming at us very fast, and I think we're all going to have to be on this side of the fence advocates for showing some degree of patience for this enormous challenge that the HSE has. We're seeing the example of Denmark. What does Denmark have? Denmark has a very well-resourced public health infrastructure, but it also has a unique health identifier, really good health data systems. There's obviously helped by the fact that everyone in Denmark has an identity card, and they're able to target their marketing of their vaccines very effectively, and they're stealing a bit of a march because of that. Our system, despite having many of the legislative building blocks in place, even the technical building blocks in place, for a variety of reasons, doesn't have a universal or individual health identifier, doesn't have the connected up systems, reasonably good data in the acutes, very poor data outside the acutes, although some good in IT infrastructure and general practice and so on. So when it comes to doing an endeavour such as we're doing now with the vaccine, we're starting a few steps back. And that, I think, goes back to the point I was making before. We need to equip our clinical and other staff in healthcare with the tools to enable them to do the best job they can for a patient, irrespective of setting. And we're too settings oriented and don't have enough of the connective tissue that most health systems have. So I would do that, and that would then empower more evidence-based decision making and more clinical leadership.
Now, what we do, I understand there is a health identifier, but it's not rolled out, or there are obstacles to it being implemented. So rather than is that when you say do that, Tony, that's not a big IT project, is it? Or is it a governance and legislative project? What is actually involved in actually implementing what you'd like to see?
Well, the number exists in that the HSE has a thing called the Primary Care Reimbursement Service, which has allocated a number which is unique and can be tracked. There is some investment required in order to enable the various systems that exist in the health system to be connected together. And there is some governance issues to be done, but there was a huge amount of policy work done in the Department of Health. There's a piece of legislation been passed, and we need to prioritize resources for it and press go on the relevant statutory instruments in order for it to happen. Now, it doesn't happen overnight. It takes time. It's one of those slow burn processes, but unless we start, we won't get to the end of it. And if we had it now, we'd be so much better off.
Vincent, what do you think is the most important sort of next reform or next big policy change that should be addressed sort of with some urgency?
Yeah, we're over endowed with plans and kind of under endowed with enablers. I reinforce two of Tony's ones there. It's kind of about the boring stuff for me. So we need to really get serious about information sets and using them, deploying them, and IT. I'd add two maybe. One is we need to align the financial incentives within our health system much more sensibly. The way we pay for stuff generally works against all the plans. So, for example, if you look at the public health system and you think of how money gets to the provider for certain things, you mentioned fair deal, that's one approach. Then there's medical cards, that's another approach. Then there's the way we pay hospitals. We studied that last year, and we reckoned there were 24 different banks, if you call them that, within the health system. And like, follow the money is the thing. I think we need to get much more aligned between the financial incentives. So that's saying a lot in a single thing. The other thing that we're missing on is a kind of coherent approach. Let's call it licensing. Like the pharma industry is regulated within an inch of its life in terms of therapeutic assessment and stuff. But you don't have to. You have a license to have a dog in Ireland. You don't have to have a license to open a hospital, which is extraordinary. So this is the boring sinews and muscle of our health system, which allow you then to do the fancy stuff. So I would add those two to the enablers that Tony spoke of.
Okay, so just before we go to questions then, let me ask you, are there any specific lessons you might take for our industry, pharmaceutical, in terms of the originator industry, particularly in terms of how we might address, new medicines reimbursement or expenditure policy through an agreement and otherwise, given what we've said about reform and given the circumstances we're in at the moment?
Yeah, I think the opportunity, and let's be clear, one of the main reasons why life expectancy grows in Ireland and the rest of Europe is the benefits that come from pharmaceutical discovery and the deployment of same. And we all know that we have been relatively slow in recent years to allow such new products into the marketplace. So what is the challenge? I think the challenge is to find new ways of tracking the benefits and charging for the benefits of those products that reflect the fact that at some point the budget is finite and needs to be redistributed. So if I was in the Pharmaceutical Healthcare Association, I think I'd be advocating very strongly for the type of data systems in the health system that would enable you to do that. And the ability, many pharmaceutical companies put money into registries around the drugs that are deployed, but don't get access to the data. So the ability to use real world data to decide how we continue to authorize drugs for reimbursement and at what level they're reimbursed and for which patients they're reimbursed. It's, I think, a win for the industry and a win for the system. So I would probably advocate moving more towards that as the primary agenda and less away from the big periodic agreements that obviously have to be done, but they don't really move the dial. They just move us forward in time, and they don't fundamentally change the way we're getting access to new drugs. Obviously, this year there's a big uplift in the budget for new drugs, but it's still not enough if we just keep doing things the old way.
Vincent?
Yeah, there's no doubt that the kind of the currency or the impact of the evidence-based argument, the pandemic has been a good case study for that, or use case for that. Couldn't agree with that. The other thing maybe is that it and this won't help all dimensions of pharma, but in a sense, we've got a very good case study in the importance of prevention rather than cure. So to the extent that if we call it the Healthy Ireland agenda or the health and well-being agenda, I think that everyone is now beginning to realize the extent to which health protection and promotion is extremely important. So beyond vaccines, there are plenty of pharmaceutical therapies which can prevent secondary or tertiary events, and I think that there's a new case to be explored there as well as the big one.
Yeah, that's great. Obviously I have a perspective on this, and it's a very live issue, and clearly you're both right. This is not just about the technicalities of an agreement which comes up every 4 years or 5 years or whatever. The first thing says that there is not just an opportunity, but there's a reality now of much closer cooperation between the pharmaceutical industry and state authorities in a proper way, and we've seen how that can be done in a proper way because of the pandemic.
Yeah.
The data is absolutely essential, and it's going to be even more essential as we go along, and especially as new therapies, especially advanced therapeutic and medical products come in. The whole data management and data services around that is even something that IDA Ireland and others are talking about, having Ireland being able to offer international services in that regard. Well, of course, we'd like to have those services happen in our hospitals too. And so that's why investment in data and investment in information infrastructure is really important for not just for the future and long term, but right now. And it's a vital thing. And yes, we do have our industry has to look at the OTC products as helpful as well, but also to say, look, part of the reforms process that, for example, Sláinte Care should include methodologies to adopt new technologies or new therapies in a much more focused way. So, Emer, there are a few questions I think that you'd like to ask from our audience.
Indeed. So the first question comes from Helen O'Dwyer, and she's wondering, what are your views on the communication re-COVID vaccine rollout and education of the public?
It's definitely not for me. So I think, how about you, Tony?
Well, I think we have to give those in charge of this a bit of a break. When you look at the basket of candidate vaccines and the pace at which they're being approved and the different technological challenges associated with each of them, the demand that we should have a very simple plan that we can all look at and say, well, that's when I'm going to be vaccinated, that's an unrealistic plan. Against that, I think there was a misstep, the famous St. Stephen's Day photo opportunity with all the lads standing around what amounted to a shopping trolley load of vaccines, created a level of expectation that was unrealistic. So it's a challenge, and I don't underestimate the challenge, but clearly at the moment that communications agenda has gone somewhat awry. So I think we need to temper expectations, but we're clearly looking at a situation where it's going to take the best part of the year, most likely, to get the population double vaccinated. And that's a difficult political message because we were sold on the message of having Christmas and now we're sold on the message of maybe having Easter. There's a reality. We're about halfway through what we understand to be the likely shape of this pandemic, but we also can have surprises such as we had with the newly identified variants. We don't know what real impact they're going to have and so on. So I think there needs to be an absolutely honest but clear, consistent message around vaccines, and that message hasn't been completely consistent yet. But we also have to, I think, where we can, raise our voices to give those guys a bit of a break, because there are lots of things they just don't know. There are too many variables right now for them to be definitive about their plans.
Vincent, do you have a view on this?
Only to add that this is a brilliant example of the problems that arise when you don't get the boring stuff right. If we had universal individual identifiers, it would be much easier to control and target the rollouts. And of course, the communications spin-off from that is that the government won't want to be pointing to that as a reason why it's difficult to control the rollout. So it's a case study in it, if you wish.
Perfect. Another question here from Catherine Ostwald from Y4. Do you think socioeconomic benefits might be included in HTAs in Ireland in the future? We are observing changing perceptions across Europe, for example, in Germany, that may gradually include socioeconomic data points and perspectives. I know Oliver referred to that report there earlier, so just wondering your views on that.
I jump in, Tony. I think absolutely would be my answer to that. In fact, there has been some movement in the last year or so within the HSE. The drug group itself, I suppose, represents a little bit that dimension. But when you look at the effect of the pandemic in the way we described in terms of the importance of the wider social impact of what might be considered narrow clinical issues heretofore, I'd be absolutely certain it will be a development.
Yeah, I agree, and I think that the pandemic has changed our collective perception of what health and well-being actually means.
Yeah.
Perfect. And one more question here from Adrian Fenlon of Janssen. We know that patient UHIs are an essential step in enabling our health service to be more efficient and progressive, plus having more connected systems, financial registries to measure, or WOs, etc. But we seem to be talking about the importance of these for the last decade at least. What is the real barrier to addressing these problems? Is it finance, is it willingness, or is it politics?
It's all three, obviously. I think there is a willingness at a high level, but it's a question of the urgency with which that's being addressed. There is a financial component. For historical reasons, the health system was somewhat starved of IT money for quite a period of time. There is a good e-health strategy. It needs to be fast-tracked. And we're basically dealing with a lost decade when it comes to health IT and architecture and infrastructure, and we're just in a catch-up mode, and we're now paying the price for that, unfortunately.
I would add before we finish something I forgot to say earlier. When Tony was talking about the cancer strategy and so on, indeed this is part of coming back to this question of priorities. First of all, I want to make a shout out for the then Deputy Chief Medical Officer, Dr. Tony Holohan, who was a very strong driver in that cancer strategy, and in fact, I think sourced Tom Keane for us. So at a long meeting, a whole day or day and a half meetings over in Vancouver, one time, which was a seminal meeting, and Tony did fantastic work with his colleagues in oncology in driving that along, and then in helping the minister make her commitment to it. So a shout out for Tony's work of 15 years ago, and here he is still doing a lot of work for the public. Second thing on that question of prioritization, I found that in the, health is so big, and when Tony was at the level of Director General or Chief Executive of the HSE, tons of things coming up to you. And similarly with the Minister's desk, tons of things coming up. How do you prioritise? And I think you do have to, at the end of the day, you do have to say for the foreseeable period ahead, whether it's 1 year or half a year or whatever, there are three really top priorities that I'm going to do. And I would strongly agree with you, Tony and Vincent, that if our current minister was, when he is able to get out of the pandemic, and say, I'm really going to do something about this health data infrastructure. It would have long-lasting beneficial effects. It's not going to be a big thing that you're going to sell to the public, but it is so necessary, and it would be great to answer Adrian's question. Adrian, the answer could be done if it were it is about prioritization and say this is going to be a top priority, and you simply have to treat it that way. I think you'd agree, Vincent and Tony, no?
Yeah, absolutely.
Yeah, Tony has put it gently. If I put it a bit more bluntly, outside the hospital sector, we really know almost nothing about what the activity is, what the benefit is, and what the cost of it is. So for someone like Robert Watt, that might, I don't mean to personalize, that might have suited him actually, because the kind of investment cases that health could put up were on shaky enough ground. So that was my gig for a while. But now he's sitting looking the other way. And I would think there's probably a good opportunity that he'll say, I need high quality material here to go into battle. So the planets could be aligned.
Great.
Yeah, absolutely.
I think we're at the time, Emer, are we?
Yes, we are indeed. I promised an hour, so we're just gone past the hour there. If there's any other questions, people can just type them in, and I can always pass them on to you. So just on behalf of Oliver, myself, and the team in IPHA, I'd like to thank Vincent and Tony for your time today. That was a fascinating discussion. We have recorded this session, so if anybody would like it, I can forward it around. And for now, I think everybody probably wants a cup of coffee and their lunch and whatever. So I will say goodbye and thank you.
Thank you very much, Emer and Tony. Thank you. Bye-bye.
Bye.
Thank you.